Hello, everybody. I just want to thank the symposium committee, Beth Oliver, Heidi Garcia, Jennifer Del Campo, for inviting me for this conference and speaking to you guys about peripheral arterial disease. Very important kind of subject to talk about, only because you're going to see more and more of these types of patients in the cath lab because we are treating them better in the cath lab setting. So without further ado, another disclaimer: if my slides get you motion sickness, I don't mind you walking out because for some reason I put a lot of keynote stuff in this. So no disclosures. Just to start with is what is peripheral arterial disease? Well, as we know, like in coronary artery disease, PD is an obstruction of blood flow in non-coronary and extracranial arteries, and it affects a lot of people, pretty much 8 to 12 million Americans. 40 to 60% of PAD patients also have coronary and cerebral artery disease. Just patient demographics, of course, PAD hits a lot of patients that are much older and who have pretty much have diabetes and smoking and high blood pressure. Prevalence of PAD, another slide showing if you just go at the bottom here, you see that older patients and patients with history of diabetes and smoking, 1/3 of these type of patients may have encountered some PAD symptoms. Risk factors, of course, increase your PAD and also your CAD likelihood to have smoking, diabetes, hypertension is the major things that come. High cholesterol also is another situation that you may have patients with coming with peripheral arterial disease. Again, just risk factors. Again, 70-year-old patients with coronary artery disease would probably have also concomitant PAD. Just a couple of slides I put in here. Believe it or not, this is really kind of sad in a sense because patients with diabetics, this is the rules of 15. If you think about it, 50% of diabetic patients who have a foot ulcer in their lifetime will have developed a foot ulcer. 15% of those patients will, foot ulcers will develop as osteomyelitis, and 50% of those patients will, believe it or not, with osteomyelitis will lead to an amputation. Another slide with the rule of 50 is that 15% of those patients who have osteomyelitis, 50 of them will have an amputation. 50 of those patients will have a second amputation, and believe it or not, 50% of those patients will not survive within 5 years if they have a double amputation. So clinical presentations of claudication. Classic claudication basically is a reproducible pain. As patients walk, they tell you that they have pain in their legs, and they'll give you a specific distance. I could walk 1 block, I could walk 2 blocks. Atypical claudication, pain in the legs could happen anytime. They could be walking, they could be sitting, those kind of things. And of course, critical limb and acute limb ischemia is kind of self-explanatory. Critical limb with gangrene, non-healing wound. And acute limb ischemia, we have the 5 Ps, which is pain, pulselessness, pallor, paresthesia, and paralysis. And once paralysis hits, it's really kind of the end of that limb, unfortunately, because it loses a lot of neuromuscular sensation. Some differential diagnosis that you could look at: claudication against pseudoclaudication. I kind of expressed that in the other slide. You have crampness and tightness, but exercise-induced is what's important. Pseudoclaudication, like I said, could occur at any time, walking or not walking. Other types of for your types of claudication for your we would have cramping, you have bursting and venous claudication, and you would have electric shock and neuro. So you could have all these type of claudications, but not really your true intermittent claudication with ambulation. So these are the ACCHA guidelines for management of PAD. You do your history, you have them walk, you have them. You get leg discomfort or exertions, you look at their leg pain. So what do you do next? Basically, you go and do what we call an ABI, ankle brachial index measurement. And the proper way of doing this is the slide on the left here shows you that you get the ratio of the higher brachial systolic pressure and then the higher ankle systolic pressure, and then you kind of do the math. So that's a resting ABI. Exercise ABIs is when you put a patient on a treadmill. You do the same type of kind of calculation. And exercise ABR is a little bit better or a lot better than resting ABIs because it may unmask PAD when the resting ABI is normal, but it also takes a little more time. What do the numbers mean? Excuse me. So ABIs from 1 to 1.2, pretty normal. Anything below that gives you a borderline to mild to moderate disease. 1.3, anything which is super normal, which is greater than 1.3, could mean non-compressible arteries, which is very calcified arteries, so it gives you a false number. ABI limitations, again, non-compressible, and normal resting values, symptomatic patients may become abnormal after exercise. Along with ABIs, we do segmental pressures. The way we do this is basically having blood pressure cuffs along several areas of the lower extremities, and we measure the pressures between those cuffs. And a drop of 30%, 30 millimeters between the levels is significant, and a drop between 20 millimeters of mercury between the limbs is significant. Segmental pressures, this is how you read them. Normal pressures will have a normal dichrotic notch and normal waveform, and as we go along with severe, you'll have a dampening of these waveforms. ABI and segmental pressures are widely available, cheap and reproducible. Some disadvantages are technical dependency. If your technician is not that good, your results are not that good. Time consuming, takes a little longer, and detection of collateral is very low in these types of tests. So we have arterial duplex, very helpful in looking at some anatomical location and where the stenosis actually really is. You have also, kind of the waveforms of the duplex, very sensitive, very specific to stenosis in the lower extremities. You have other types of measurements or types of imaging. You have MRA that'll help you to take a look at other structures of the lower extremities, and you have CTAs. But in order to have this type of image with a CTA, you're gonna need a more sophisticated type of CT machine in your hospital. Okay, so you got PAD. Patients come to you, and the initial treatment is you do medical non-invasive management of PAD, and what I mean by that is medical treatment. So again, I'm sorry about this. Lower extremity of PAD. You're going to start them with pharmacotherapy, and therapeutic supervised exercise program is also a type of non-invasive management for PAD initially. We have 2 drugs that we use to start patients on who have claudication. We have Trentol, we have Solocitol. We also, this slides just show you the effects of Solocitol and Trentol in patients with PAD. Solocitol has a lot of kind of effects, pharmacological effects on the patient, which is beneficial, especially for our patients with CAD. Increases blood flow, increases HDL, decreases triglycerides, those kind of things. Just a few more slides showing that patients placed on these types of medications do walk a lot better, walk longer distances than those who do not take medications at all. And the other sides also kind of depict that. And again, with these types of medications, patients do much better in terms of their activity. And the quality of life increases because the more you walk, of course, the more things you want to do throughout your life. Dr. Barber talked about some bleeding situation. Basically, we do put these patients on Solocitol even though they're on aspirin or clopidogrel. But if you see on this slide, clopidogrel, helps reduce ischemic events, but does not improve claudication symptoms. Solocitol does not reduce ischemic events, but do help improve. So, you put these two medications together, it kind of helps out the patient, benefits the patients a lot better. The only problem with placing patients on Solocitol is basically if they have a history of diagnosis of CHF, because it exacerbates the CHF and the outcome is not good for that patient. Exercise training program is what you do in telling patients to do your exercise. It helps with extending their walking. Basically, this has to be supervised because if you tell the patient, say, go out and do your walking, some patients don't do that. So you have to have these patients come in and kind of watch them do their exercise. And this is the training prescription that they need. You start them slowly, and you get them going for 3 to 5 times a week, and the walking it gets better. So now, endovascular management, what's in our toolbox when these patients come into you and how we could help them in the cath lab. Planar balloon angioplasty, as you know, works. We could do that. This kind of data just shows that technical success rate is fairly simple to use, and primary patency is 89% after 1 year, and about 88% is after 2 to 3 years. Balloon stenting is also another type of procedure we could do in the cath lab. Again, technical success is 95%, and patency rates about 88% after 1 to 3 years. Very easy to do. This slide is just to show you that stents placed in patients with iliac stenting and PTA, their patency rates are very high because of just the kind of anatomy of the artery there. It's much bigger than the RSFAs or below the knee, which kind of shows you down here saying that FEMPOP, PTA, patency rates are pretty good after 1 year. And PTA with stent also, again, pretty good after 1 to 3 years after they do that. New stents on the market, we have Supera stents, which is a single interwoven stent that kind of bends and flexes with the arterial system in the leg. And we do have new drug-coated stents called Zilver PTX, made by, I won't say it, but PTX. The data here shows also just showing that if you put stents in these patients, they do much better rather than just angioplasty. Their patency rates is a lot greater than those with angioplasty. And also that patients walk more, I guess I wouldn't say better, but walk more distance with stenting than angioplasty alone. So in conclusion, in the intermediate term, treatments of superficial SFA arteries diseased by primary implantation of self-expanding nitinol stents yielded results that were superior to those with just balloon angioplasty. So we know that. Some devices that we use in the cath lab are directional atherectomy devices, rotational and laser. The Silverhawk or Hawk 1 atherectomy device is a carbine cutter which spins at least now with the new Hawk 1's 14,000 RPMs, and what it does is actually takes plaque out of the arterial system. I'll show you a little bit of animation, just how it works, so you know what I'm talking about. Basically, these devices and all our procedures are done with a wire over the lesion already. And this is a directional atherectomy, which means we could direct where we want to cut. We could direct the cutter where we want to have the cutter. So we have large arterial systems, and we have a small arterial system, and this is a large vessel plaque incision. And basically what it's showing is you have disease in the artery. This device comes down over the wire, and what it does is when you turn the device on, the cutter opposes the arterial wall and cuts the plaque out. So it's basically kind of shaving the plaque, pushing it into the nose cone, kind of serving cheese at this point, and then the nose cone will then kind of push the plaque into the nose cone so that the debris is not embolized distally. Show you another one. It's this basically, which then is showing you that we could direct it in another direction, and it'll cut again the same way. Good for eccentric plaque, meaning one side or the other. Good for calcified plaque also, but here we're showing soft plaque that's being excised out of the artery. Very satisfying device, only because what yields it is this much stuff you could get out of the artery. This is about, I guess, 4 or 5 cuts in the artery, about 100 millimeter length, and this is what we can get out of it. Some sort of data saying that it's a successful kind of device that helps diabetic patients with PAD. Another atherectomy device is laser atherectomy. Basically, it's a device that has energy component to it ahead of it, which they say kind of pulverizes the stenosis. FDA approved for in-stent restenosis. That's why we have a stent in the arterial wall here right now. And basically, a wire is passing through. And we have the device which has an energy to it, kind of pulverizes the energy, the plaque. You can increase the bubble by increasing the fluency and the rate, and that you get a better, bigger lumen. Pathway atherectomy device, very good device for very calcified lesions. You have your lesion here in the right common femoral artery, and then the device is being here shown on this side. Blades up basically kind of have the device kind of rotor through the artery, balloon angioplasty afterwards, and the results is this. So very good devices that we use here to help patients with PAD. It would be amiss if I don't talk about the latest sexy thing out on the market right now, which is the drug-coated balloons. Basically, the scaffolding of the drug is the coating process. They use paclitaxel for this balloon, the excipient that helps transfer the drug to the wall, and the balloon platform. There are a lot of DCB drug-coated balloons out there on the market now. Lutonix Impact is in. And the durability, developability, and uptake is what kind of drives the performance of this balloon. Just a little slide to show you that when we do directional atherectomy or any type of atherectomy or balloon angioplasty, we kind of start the kind of cascade of the restenotic cascade. So it happens immediately and it lasts for days. And what this balloon does, it kind of reduces that inflammatory response in between these two parts of the cascade to help reduce the restenosis rate. And again, the same sort of slide kind of showing you the days and when those things happen. Calcium is a problem with the balloon angioplasty. As you can see here, calcium, if you have a high grade of calcium in the vessel, it results in a higher late luminal loss and a lower patency rate in 12 months. This slide just shows you the length of the stenosis. The shorter the length, the more patent the vessel is, versus the greater the length, you have a higher restenosis rate. And the current DCB landscape, basically, we have 3-year data out now, but the Impact SFA is a balloon that we use, and after 2 years, it's still about 90% patent the vessel, which is very good. Just to show you some case photos, baseline, as you can see here, we use the DCB, post-DCB 6 months follow-up, very nice. Same thing with, on this side, this is the standard side, is showing you both legs. After 6 months, you can see there's restenosis that developed here, but still the DCB1 is still patent. Again, of the case photos, showing you the same situation where regular PTA gets you restenosis after 6 months follow-up, while DCB has that still patency that's very nice. Again, more case photos just to show you how DCB could work after 6 months follow-up. So very nice things that we could do here for our patients in the cath lab. And thank you very much.